Madam Chair.
Oh, okay. Thank you. This is the posted time and place for the board meeting for the Silver State Health Insurance Exchange. Before I have Mr. Hager take the roll call, I just want to let everybody know that they will most definitely shut down the transmission at 4:30 today. So that's why we're starting a little bit earlier today, too. So I appreciate everyone letting us start this meeting at 1 o'clock today. With that, I'm going to have Mr. Hager take the roll call.
Ms. Edkins?
Present.
Ms. Lewis? Absent?
Present.
Oh, she's here. Excellent. Dr. Klein?
Present.
And Ms. Kerr is absent. Dr. Ford?
Present.
Director Wilden?
Present in Carson City.
Director Johnson? And I believe he had a prior engagement, so he's absent as well. Director Mollenkamp?
Here.
Vice Chair Johnstone?
Present.
And Chair Campbell?
Here.
And we have a quorum.
Thank you very much. We do have a fairly lengthy agenda today, and so before we start public comment, I encourage it, I just want to let everyone know that we'll be limiting it to 3 minutes per person. So, yes, you may.
Also, you might notice on the agenda, agenda item 8C, which is recommendation 4, was deferred to the October board meeting. That is the plan for navigators, producers, and outreach specialists. Again, that one has been deferred until October. Additionally, the recommendation number 2 for item E, the recommendation for risk adjustment has also been deferred for October, and those have been deferred simply to give us enough time to discuss all these other items. It's not pressing that we get those done, the other 2 items done today, so we've deferred those. So that's why we've done it. It was provided in a packet so that we had a complete set of recommendations that have been provided by the committee. It makes it easier for us to move them from one place to the approved recommendations list. But we're not. We don't plan on discussing those 2 items today. Madam Chair.
All right, thank you. We'll open it up for agenda item number 2, which is public comment. And Ms. Johnstone, will you help me with taking care of things down in Las Vegas, please? Is there anyone there in Las Vegas that would like to make a public comment?
It doesn't look like it, Madam Chair.
Okay. How about here in Carson City? Okay, and do we have telephone participation today?
Yes.
Okay. I will ask if there's anyone joining us by telephone, if there's any public comment from those participants. All right. Thank you very much. We'll close agenda item number 2. Item number 3 is approval of the minutes from August 16th. Do we have any amendments or edits or changes to those minutes? Hearing none, is there a motion to approve?
Winetkin so moved.
Do we have a second?
Is Dr. Ford, I second.
Thank you. All in favor of the motion?
Aye.
Aye.
Any opposed? Motion carries. Thank you. We'll go on to agenda item number 4, which is the Executive Director's report.
For the record, John Hager, Executive Director. The agenda item number 4 gives us a status of the exchange implementation. We are starting our countdown, 383 days to go till October 1st as of today. The advisory committees have made 24 policy recommendations to the board. The board has already approved 12 of them. 10 of the recommendations will be discussed today, and then the remaining 2 will be discussed in October. Additionally, we expect to see another half dozen to dozen recommendations from the committees over the next couple of months. But that phase of the implementation should be winding down, so we are getting away from the policy decision process and starting to actually get into full-blown implementation, the technical implementation. So we're going to be taking those policy decisions, those business rules, and putting them into the system, making sure that they work, starting with testing and those kinds of things. The other thing that we still have to do is we will have to set regulations very soon. So we probably will start that in November, December timeframe, go through January or February, and at that point we should be done with the regulation process as well. So I think we will be able to cancel one of the meetings this fall, potentially either the October or December meeting. And then after January or February, we may be able to start winding down to a once every other month board meeting, which should help everybody's schedules immensely, I'm sure, because they're probably exhausted by all of the committee and board meetings, and I appreciate everybody's hard work in reviewing all of the materials. The legislative session begins February 4th, and while we will be providing regular updates, I don't know if we would necessarily need to have board meetings regularly at that time, but we can schedule them via phone if we need to, but they should be relatively minimal for the legislative updates. Technical implementation, we have an executed contract with Xerox for the business operations solution. We've had several kickoff meetings and other implementation meetings with Xerox, Deloitte, Welfare, Medicaid, so those are moving along fairly nicely. We are expecting to receive the first deliverables from Xerox any day now. And that's pretty much where we're at for that item. Funding, we've received all of the expected grant funding for the exchange, $74,754,000 worth of grant funding, or at least the NOGAs. We've got the awards for it. We don't actually get the money until we spend it, so it's a misnomer when you say you got the money. But we have received awards for those items. Nevada is one of 6 states to receive Level 2 grant awards. We are of those 6, only Rhode Island has less money requested, and they were the ones that requested it back in October. They also have about 1/6 the estimated enrollment that we do, so that plays a big factor on the costs. The advisory committees, you can see an update of the 5 advisory committees. Finance and Sustainability, pending any requests from the board to look at any specific item, the Finance and Sustainability Committee is done with their work. Plan certification and management, a lot of their recommendations are in this packet. We discussed essential health benefits this morning, and we'll be discussing that at Tuesday's board meeting. They have a few more decisions to make, but they are almost done. Consumer assistance has a recommendation that will be discussed at the October meeting for the navigators and producers. They will also discuss web brokers and a couple of other issues such as appeals and complaints and how we deal with those items. So their work is nearing completion in the next couple of months. The shop exchange, pending the decisions that are made by the board today, will be complete. And then reinsurance and risk adjustment has 2 meetings in October. They've made one recommendation regarding risk adjustment. They've got some more analysis to do on reinsurance, and that will come before the November board meeting. You can see the committee calendar that we have here. Again, it's starting to become a little bit more lean, so hopefully you can breathe a little bit of a sigh of relief. The status of the contracts are available for you to review, and the board calendar is there as well. Obviously subject to change, but we're trying to keep up with it and make sure that items are still getting done when they need to get done. And with that, I'll be happy to take any questions.
Do we have any questions from Las Vegas? And any questions here from members here in Carson City? Seeing none, let's move on to agenda item number, where are we at? Number 5 for the memorandum.
Good afternoon. For the record, Shauna Drews, Chief Operating Officer for the Exchange. Attached in your packet is the Memorandum of Understanding that has been provided to Directors Johnson and Wilden. This Memorandum of Understanding is what we've been using, a lean document that describes the roles of each of the agencies, who will be the lead for those roles, and who else will be participating in each of those items. I would say that the 3 divisions and departments are working very, very well together. We talk on a daily basis, and we didn't feel that there was a need to go into huge detail here. Sometimes when you have more detail, it mires you down. So I think that we felt that as long as it was going along so well, keep it lean, keep it easy, and deal with any issues that came up as they happened. So I know you've asked for this for the last few months, and it's presented here for your review.
Okay, thank you. And just procedurally, we do not need to approve this. This is done internally, correct? This is just for our information. Thank you. Do any of the board members have any questions of Mr. Hager or Shauna regarding the memorandum of understanding?
Madam Chair, Lynn Atkins, I have a couple of questions.
Yes, go ahead.
Under customer service for consumer complaints and appeals, I know that our subcommittee has yet to discuss the appeals, what the appeals might mean, the appeals process, and I also know that there's a staffing request for an appeals officer at the exchange. We've also are going to be discussing the premium billing with Xerox, and I'm just wondering how it is that the Division of Insurance will be taking the lead on that role and how that's going to work. So that one just struck me as, I just had some questions about that. And then the second question is under navigators, the certification or licensing. I think at our last consumer assistance meeting, we absolutely agreed that the Division of Insurance would be in charge of actually implementation and licensing the navigators, yet there's still discussion about what those certification items are going to be, and that the Consumer Assistance Subcommittee was going to be making recommendations to the board for recommendations to the Division of Insurance, and so I don't know if that one might need to be broken up into two. So those are my two questions.
For the record, John Hager, Commissioner Kipper's coming up. But generally what we've done, so you have brokers that will be providing customer service and you have navigators that will be providing customer service. Brokers are obviously licensed by the Division of Insurance, and the plan that was recommended by the committee was that the navigators be certified or licensed light by the Division of Insurance in cooperation with the exchange. So they are taking lead on that aspect of complaints and appeals. We are trying to build, and we'll discuss that in the next item, an appeals function for those items that the committees and the board decide should go beyond what Xerox does and go into the exchange staff appeal type realm. We still need to work on that, of course, but there also might be items that the Division of Insurance wants to be part of, and we do think it's appropriate that because they take lead on insurance complaints and appeals, that they be in charge or take the lead step on that. But we do work very well together, and so they're not going off half-cocked and doing stuff that we don't want, and vice versa. So it's almost a dual lead function there. For the I'll let Shauna take the second part of the question. Oh, I thought you had it. All right, I apologize.
Ms. Atkins, do you want to repeat your second question, please?
Sure. I guess can I just get a clarification on what Mr. Hager was saying? So the consumer complaints and appeals, that's the contemplation here is more the complaints about the navigators or about the brokers rather than about the exchange or the billing or the website or the denial of benefits, or am I getting too much into the weeds?
I'm going to let Commissioner Kipper speak in a second here, but complaints about navigators and certainly about brokers will go to DOI. The navigators is kind of a dual function. They're going to certify them or license them, the license light, however you want to call it, and so they'll have those complaints. But we will also have the stick of their funding. So the be good or we can take away your funding. So that part will have a part of that. For complaints about Xerox, generally it's a contractual issue, but they are a TPA, and therefore the Division of Insurance has some say over those types of complaints. And then as far as benefits go, most of that will be done at the division because the benefits section is really a certification and licensing of the products that's done at the division level. If you recall, we recommended that the division do rate review, and part of that is a certification. We will be providing recommendations for things that should be included in the certification process, but as the division already has resources that can do rate review. They will likely be responsible for the certification and the complaints that come regarding those plans. But as they appear on the Xerox solution, generally we will be taking those complaints. Again, this is a very broad MOU, and we do work very well together to make sure that everything runs smoothly. Commissioner, you have something to add?
Good afternoon, Madam Chair. For the record, my name is Scott Kipper. I'm the Insurance Commissioner for the state of Nevada. And I don't think I could add too much to what John very eloquently stated there. There's certainly a significant level of cooperation and collaboration between not only the exchange and ourselves, but also our work with the Department of Health and Human Services and Director Weldon. I think the issues around consumer complaints, if I could really simplify this, if it's an insurance issue, if it has anything to do with the insurance product or the way that the consumer has been had his benefits or her benefits adjudicated, certainly those would continue to come to our office as an insurance complaint, and we would act accordingly. When a complaint would come in against Xerox when they're acting as a TPA, for example, I think that's one of those issues where we would sit down and work very intimately with the exchange staff to determine where that problem is and whether or not this would be a contractual issue with Xerox and their contract with the state, which I think then we would have to adjudicate through the exchange or some other similar process. But if it's in their capacity acting as a third-party administrator administering benefits, then certainly we would step up and try to adjudicate that complaint that way. And Ms. Edkins, I hope that clarifies your question.
It does. Thank you very much.
Ms. Atkins, did you have a second question to that, or was that pretty
I did,
comprehensive?
but I think I think John probably answered it a little bit in the first one. I mean, again, I think I might be getting a little bit further in the weeds than this is intended. But the certification and licensing, it is my understanding that the Division of Insurance is going to be managing that, certifying, light certifying, all of that, but that there's still discussion about what those certifications are going to be for the navigators. So I guess I just wanted to make sure that that was, everyone was in agreement on that.
Okay, thank you. Do we have any other questions for Commissioner Kipper? Commissioner, I am going to ask you a question because it came up in the Plan Certification Committee, and I know you've got a busy afternoon. So one of the questions that came up today was, what is the process once we have made recommendations to your office? And maybe you can give us just a high-level overview of what that's going to look like.
Certainly. Again, for the record, Scott Kipper from the Division of Insurance. That's a great question. We anticipate having a recommendation ready on behalf of the state of Nevada to the Secretary by the end of this month. We certainly appreciate all the work that has taken place through the committee process and through the board, and certainly will take those recommendations very, very seriously. One of the other things that we are planning on doing that we have, in fact, putting the final touches on, is a series of public meetings or public hearings across the state so that all Nevadans have an opportunity to weigh in and express their desires as to what they feel should be in the essential health benefits. And we hope to have those meetings complete well before the deadline of September 30th. We understand that there's some discussion as whether or not this is a soft or a little less than rigid deadline, but we intend on meeting that deadline, and if we need to adjust or further articulate the state's position, we'll have the ability to do so during a public comment period that starts in October.
And just one further question for those that aren't familiar with the Division of Industry, or Insurance, I'm sorry. Those are publicly noticed 3 days in advance, and will be noticed on your website so that people can track it then.
Absolutely. At this point, tentatively, and I'm hesitant to commit to it because The details have not been finalized, but we believe that it'd be one meeting in Elko, one in the Reno-Carson area, and then 2 meetings in Las Vegas, given the size of the community there.
Great, I appreciate that. Thank you. Do any of the other board members have anything else to ask of Commissioner Kipper, or if you want to add to the dialogue today? All right, being done, thank you very much. Getting back to the memorandum of understanding, were there any other questions from any of the other board members regarding the memorandum? Being none here, thank you very much. We'll close agenda item number 5. Agenda item number 6 are updates on the exchange staffing plan. So I will, is this Mr. Roos? Okay, thank you.
Again, for the record, Shauna DeRose. Agenda item number 6 is an update to the exchange staffing plan that was presented to the board back in March. I know it's been like dog years and we've done an awful lot of work between then and now. At that time, we brought a plan to the board that was a long-term plan that would eventually get 13 employees to the exchange. We had 4 at that time, and we requested that 4 more be taken to start early in May. That included the IT officer, the finance and research officer, the communications officer, and the administrative assistant. We had an additional staff plan that starting in July of 2012 would be an accounting HR assistant, a contract specialist, a quality assurance specialist, and then next July 2013 an IT analyst and a benefits manager. And not having that crystal ball, we thought that was our plan at the time. The IFC in April, they approved the 4 that I mentioned earlier and asked us to come back at a later date to request those additional staff when we had a little bit more information. So in the months since that April IFC, we've filled our IT officer, communications officer, and finance and research officer and admin assistant. And as we've been working with the other state agencies, it became clear that perhaps the accounting HR assistant would not be as needed as we originally thought. The Division of HR Management has been so helpful to us and fulfilling those roles that we've needed as we've needed to hire those new staff. And then the contract specialist duties that we talked about at that time. Again, our current staff and other staff in the state, in the agencies we've been working with, they're taking on those duties. And so to deal with, work with the Xerox contract or PCG and some of those other contracts that we have approved, we don't now feel that would require an additional full-time position. With the execution of the BOSS contract with Xerox and starting down this requirements and development road, it's become clear that we really could use that IT analyst position, which we originally thought for July 2013. We could really use that one now. Because of the deadlines for the Interim Finance Committee for the October meeting, we did a work program to request that position that would start January 1st of 2013. If the October IFC is October 25th, and if they approve that position by the time the recruitment was done and interviews were done, we felt that January 3rd of 2013 was a conservative time frame to have that position start. We also then made some changes to the staffing plan due to the fact that we had to turn in our agency request budget. We changed out some of those positions and included the following positions in that plan. We included a quality assurance officer for July 2013, a hearings and appeals officer, and a benefits manager. And then for October of 2013, an additional administrative assistant that would help with the quality assurance and appeals. And as Ms. Edkins stated earlier, some of those discussions are still happening about what's going to happen with the appeals, what's going to happen, who's going to do what. We are working with our sister agencies. We're working with Welfare and Medicaid to see what they do for their appeals process, and perhaps they could help us. We've recently discovered that the Department of Administration has a whole staff and that they do appeals and that they perhaps could help us. But we had to get it in the system. We had to get that out there. Knowing that it may change and the board may decide not to accept this recommendation, but at least at that point it would be in there and it was a placeholder. So the plan still has 13 employees, but I think that this plan is definitely more focused on customer service and not so focused on the internal operations of the exchange. And that's what we're here for. That's what we're here for. So there's a table here that talks a little bit about the responsibilities of each position. I won't read through that. The costs that are here do not include fringe or the reductions due to the 2.5% furloughs that we are all taking right now. So I'll just put that out there. And then the IT analyst position would be the only position that wouldn't be fully funded with the grant at this point. We do fund our IT officer, and this IT analyst would also be funded through the approved advanced planning document that is approved by Medicaid, and there's a 5% Medicaid and CHIP funding section in there. So with that, I would take any questions.
All right, I'll open it up for questions from the members of the board. Any questions in Las Vegas?
Yeah, Madam Chair, this is Ron Klein.
Yes, Dr. Klein.
Just a question, and I don't want to get into the micromanagement of a small agency, and I hate north-south arguments. Having said that, is there any plan to have a presence here in Southern Nevada where 3/4 of the population of the state is?
So I think the largest presence that we will have in the South will be the call center. Xerox is planning to have that in the Las Vegas area, and they will be hiring from the local population there, and I think that will represent our exchange presence in the South. For the specific employees I know you're talking about for the exchange, the plan is not to have a separate exchange office. Not only would having staff members full-time in Las Vegas necessitate an entirely separate office presence, separate office receptionists and staff full-time, and that is a cost that has not been included in our long-range finance and sustainability plan. So I can just say right now that is not part of our plan.
So a communications director whose job it is to interface with all the different different corporations, companies that are purchasing plans through the exchange, sounds like that person having a presence in Southern Nevada would be a good idea.
So we do have a current communications officer, C.J. Bowden, and he definitely is on the run. He travels to Las Vegas. He just got back from Boise, and I understand what you're saying, but those positions are currently filled here. And if that position became empty going forward, those discussions could certainly take place.
LaVon Lewis, I also think that in considering your hearing officer, since 75% of the uninsured population would be located in Southern Nevada, there needs to be, and that obviously has not been developed so far, but some mechanism for those hearings to take place in Southern Nevada, since by far the majority of them will probably be about Southern Nevada residents.
Madam Chair. For the record, Jeff Molenkamp. I just wanted to offer that if there is a decision to look at the hearings and appeals office within the Department of Administration, our primary office is actually in Las Vegas, and so that's our major presence in the state. We do have a small office up north, but if that is a consideration, I think that might help fill that need. So I wanted to offer that.
Well, and I think one of the other things I wanted to offer as a comment on this is that most of us think that those appeals need to take place face-to-face, and with technology the way that it is now, we certainly will have the ability of having appeals in this type of format as well. All of it being in an effort to save costs both for the state and for whoever is appealing along the way, so that they don't have to travel. So I think all of us are cognizant of that. I'm certainly aware that Las Vegas is the population center for the state. Given that this is a brand new agency, I think that there is some benefit in having it sit in the capital, where you have the expertise of those agencies and sister agencies helping assist the formation in that new agency. So I think your comments are all well taken. I think there's a good reason for it, at least at this point in time, for it to be focused here in Carson City.
Kevin Walters.
Madam Chair, Lynn Atkins.
Yes, Ms. Atkins.
I first just want to say that I really, really appreciate that staff kind of is relooking at the budget and is shifting focus to plan for the future and to plan for consumer outreach and consumer satisfaction and appeals. And I appreciate the conversation here too. So the one thing that I've expressed at our last consumer assistance meeting, and my committee expressed as well, is I think we're worried about capacity, and we're worried about just a huge number of folks coming to the exchange, or not worried, we hope there's going to be a huge number of folks coming to the exchange and getting insurance, and therefore that we're going to have the internal support for that, including things like appeals and consumer assistance. So that being said, I think it's fabulous. Yes, absolutely, we need a hearing officer. I guess my question is, if we need more than one, if we need more of a staff for that, will we be able to support that? And I love that you're talking to some of the other agencies to try and work with them as far as how this is going to work. But if we need more, is there funding? Will we be able to hire more for the capacity?
For the record, Shauna DeRose. So to that question, if the exchange decided that we had a justification for more hearing officers or more benefits managers, whatever staff becomes necessary, we always can take that to the interim finance committee through a work program process. Speaking from a little bit of experience, I would say that October, asking for a position to start in January, right before the legislative session, has its own inherent issues. And I certainly would also not want to probably ask for new positions in July or August, right after the legislative session is over, because I think their general answer is, why didn't you ask for that during session? But absolutely, there's always that opportunity to go back and say, we didn't have this information. We didn't know that we were going to have this huge response. And knowing that people are going to be, starting that October of 2013, you hit January of 2014, this will be, it will actually be a really good time if we decide we need those people to go at that time and ask for additional positions.
Thank you. Can I ask a follow-up question? So, and also reading the PCG report on their suggested appeals process and all of the materials for today, do we have a sense of what the capacity level will be able to be handled by this hearing officer and by the exchange? Are we thinking, 100 complaints or hearings? And obviously, there's all different levels. Some will be able to be handled very quickly. Some are going to go to full hearing. What is our thought on how much this person will be able to do, understanding we haven't decided all the details about that?
For the record, John Hager. So most of that will be included in our report for the next Consumer Assistance Advisory Committee. We're gathering that information right now. Obviously, we're not exactly sure what the capacity will be, nor are we sure what the requirement will be. But I would like to point out, back in February, March, when we were discussing how we would build this product, we wanted to start with a lean staff and have vendors that could handle most of these items. And we do have plenty of money in our contractual categories to hire somebody to do this, potentially. Additionally, Xerox is set up to handle appeals. I believe they have 3 appeals officers internally, something like that. And they are required contractually to handle most of the appeals. So really what we're doing is getting ready for the potential that we feel as the exchange, that the board feels, that there is some level of appeal that rises above what Xerox can handle, and that we should take that on board. The other thing that we've got that we're trying to deal with is we don't want to create a large capacity and then have to lay people off. While it may be difficult if we have too many appeals, what we'd like to do is start with small capacity and then utilize the organizations that already do appeals if possible. And we're working again, like Ms. Drew said, with Human Resources Division and other agencies throughout the state to kind of understand what they can handle in the appeals process, so that if we get to the point where we have overflow, they should be able to assist us. So we're trying to take a gradual growth approach, and then when we need to, we can ask for more positions. It is difficult to ask for additional positions in the middle of a biennium. We are fortunate right now because we're in an implementation. They are more amenable to us adding positions before the legislative session, but in future sessions we may not be as fortunate. And again, the idea would be to either contract out the overflow appeals or to have an agreement with an agency that already does that process. So we are thinking about that, and we should have more information for the Consumer Assistance Advisory Committee for their next meeting.
Thank you both very much.
I would like to point out...
Madam Chair, this is Ms. Johnstone.
I do have a couple of questions, Madam Chair. On the quality assurance officer, this looks like a little bit higher level than what was in the original plan, and the responsibilities to audit, monitor, plan quality, rating, and management sounded like the responsibilities that DOI had lead for under the Memorandum of Understanding. So I just wanted to get clarification on what the responsibilities of this position would be versus DOI.
For the record, John Hager. So the original recommendation to the committee, I believe, was a grade 3610. Then when the staffing plan was approved, the committee also included a recommendation to increase that to as much as the IT officer. So we increased that to a 3910. The position was originally under the Finance and Research Officer. We have actually moved that out to its own quality assurance group, and you'll see on the last page of the attachment the change in the staffing plan. The quality assurance officer would not only be responsible for the hearing and appeals officer, the benefits manager, and the administrative assistants for QA and appeals. They would also be responsible for assisting us come up with policies to fine-tune the requirements to the carriers. A lot of the requirements of the Affordable Care Act is not just to maintain status quo, but to push the carriers to do better. And so they will be working on that research, those policies. They will be working with the carriers. Some of that is the role of the Division of Insurance, but they will be working very closely with the Division of Insurance for those functions for the qualified health plans as well. So yes, while the Division of Insurance has lead, we are going to be part of that.
Thank you. Madam Chair, I have a second question. The work of consumer assistance and coordinating the outreach specialist, after I came up with this question after I looked at the consumer assistance report, who's coordinating all of the outreach specialists, and is there a slot for that on this org chart?
For the record, Shauna is currently the outreach and marketing and the training of the navigators as it pertains to the exchange all falls on the communications officer, CJ Bowden. That is explicitly written in his job description. So there is not a different or an additional staff member that would do that. He has an administrative assistant that works with him to help him. And at this time, again, we feel confident that CJ can handle that job, and if he needs additional staff, we can talk about that at that time.
Okay, I would just think that the focus is very different between communications and working to get the word out versus the on-the-ground coordination of the outreach specialists. So think about that a little bit.
Any other questions, Ms. Johnstone?
No, thank you, Madam Chair.
Okay, and any other questions from board members in Las Vegas? All right. Any questions here in Carson City? Seeing none, the agenda does ask for the approval of the staffing plan. So do we have a motion from any board members to support this recommendation?
Madam Chair, Levon Lewis, I move approval of the recommendation for the staffing plan.
Thank you. Do we have a second?
Dr. Ford, I second.
Okay, we have a motion and a second to approve the recommendation on the staffing plan. All those in favor of the motion?
Aye.
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 Right. Any objections to the motion? Motion passes. Thank you. All right. We'll close agenda item number 6 and move to agenda item number 7 on the Consumer Assistance Inventory Report.
For the record, John Hager, I'm going to make this brief. The Consumer Assistance Report provided an inventory of the various nonprofit and state agencies out there that could assist us in a navigator capacity or an appeals capacity. It talks about the types of appeals that some of the state agencies get and how long the turnaround time is for those items. It talks about what other organizations are out there to assist us. It is by all means not all-inclusive. There are likely other agencies out there that could fulfill navigator or other roles. But with that, I think I'm going to leave it at that. If there are any specific questions, I'll be happy to answer them.
Madam Chair, this is Leslie Johnstone. I just have a quick comment.
She stepped out for a moment, so go ahead.
All right. I would just echo Ms. Atkins' comments earlier about this is a very nice report on consumer assistance, but it is really hard to figure out the capacity and and ranges on the traffic coming in and needing help. So advice on the future reports that are put out, I think we need to keep that in mind, that it's not just a bunch of words about how this is all going to work, but we need to do the best we can to figure out if we have the right capacity or not.
Okay, we'll make sure that's included.
And Lynn Atkins? So just for, I guess, clarification, we're expecting 100,000 newly insured people to go through the exchange during the open enrollment period of October through, when does, December? Is that the end of the October? So through October to December 15th. Is that the big picture number we're working with?
Yes, it was a little bit over 100,000 people, and it's from October 1st through March 31st for that first open enrollment.
Okay. So, okay. Just the first one, right? Okay. Thank you.
Any other questions or comments? All right, so you don't need approval on this then or anything. Okay. All right. Let's close agenda item number 7 and move on to agenda number 8. And we are going to move this out of sequence of the way this is created, right? You want to go on to item C first? Is that correct? Okay. Turn it over to you, John.
So as an introduction, this item discusses 10 of the recommendations made by the committees over the last several months. There are 5 attachments, A through E. The first attachment is is the actual recommendations that are pending board approval. The second attachment, item B, is information regarding whether the exchange should conduct individual premium billing. That report, for the most part, you saw at the August 16th board meeting. It was discussed by the Consumer Assistance Committee and then returned as a recommendation for the board. Item C, again, was provided just to ensure that the board had the whole package of items for recommendation. Again, we'll be discussing item C at the October meeting. Item D, same thing. It's the recommendations for risk adjustment. And then finally, item E, just to make sure that you have all of the recommendations that have been approved at this point. It includes all of the recommendations approved by the board. So the committee recommendations, you can see, are quite extensive. With that, I think we would like to move into the consumer assistance recommendation number 3 regarding whether the exchange should conduct individual billing. And Ms. Atkins, would you mind providing the committee's thoughts on that?
Sure. Can you give me just one moment? Well, I'm not going to read from the package. We were asked by the board at the last meeting to review the individualized premium billing from Xerox, and I think we had a lengthy discussion about it at the board meeting. That information was sent to the Consumer Assistance Subcommittee. We had lots of public comment on it. We had quite a bit of discussion on it, and we believed weighed the pros and the cons. What we came up with, which is in this package, is that we did recommend that Xerox be allowed to offer premium billing. It's our understanding that consumers will still have a choice if they want to pay directly to the carrier, but that they would be offered premium billing through Xerox. And I think just a couple of the points of concern were still the credit card processing fees, which we had talked about at the last board meeting, which came up at the consumer assistance meeting, and cash payments, if that would still be available to folks. So that's probably too general of a summary, Mr. Hager, but do you want to supplement that, or was that enough?
I will help a little bit. So the issue with credit cards comes down to the statutory change. There's a couple of different ways that we can go about this. Number one, we can allow credit cards and absorb the merchant fees in the exchange budget. Based on information that we've seen from other state agencies, we think that would increase our budget by about 10%. So we're not sure we want to do that. The other option is to, if we do individual billing, is to charge a fee for anybody that uses a card that has a merchant fee, and basically put that back on the consumer. There was concern that currently the carriers, if they charge a merchant fee, that is included in the premium, and there is a premium tax that's based on that. We have a BDR that is going through the process that we have requested that the exchange be exempt from the premium tax. So any fee that's charged pursuant to our chapter of the statutes is exempt from the premium tax calculation. So there was some concern about that at the last Consumer Assistance Committee. I think if that bill goes forward, then we will be clear of that concern. The issue is an administrative issue on getting that information to the carriers and having them pay premium taxes on that piece of it. We think that our BDR will exclude not only the fees that the exchange charges to the carriers, but also the fees, the credit card fees. And so we're going to go forward with that request with the legislature. As far as the cash payments go, again, the individual will still be allowed to pay the carrier individually, so they could pay cash that way. And I do think it's necessary that staff come up with a way to have a cash payment system other than through mail, because obviously sending cash through mail is not the best method. So we will work with Xerox to make sure that the cash methods, if the board chooses to do individual billing, we'll work to make sure that we have a method to pay cash. some of the reasons that the committee felt that it was important to do individual billing. Number one, the aggregation for family with the CHIP program and a subsidized individual. So for families that are below 200% of the federal poverty level, they would aggregate those bills. The other issue is aggregating supplemental products. The carriers, for the most part, appear to be fairly strongly opposed to the individual, to Xerox and the exchange do individual billing. They are concerned about duplication of services, renewals, the cash flows, and we will work to make sure that we'll change the cash flow methodology. Right now, I believe Xerox typically does it on a weekly basis. I think it probably makes sense to do it on a daily basis. We'll work with Xerox to establish that. And then local payments, and that's all summarized on page 11. And there was one carrier that was in support of it. That pretty much sums it up. The costs are available on page 11. The cost for 2014 would be entirely paid for by ACA grant funding. The cost for 2014 and 2016 would be paid through an increase to the fees charged to the carriers, and for the subsidized population, almost all of that would be paid. That increase would be paid for by the advanced premium tax credit. Obviously, for the unsubsidized population, the individual would have to pay for it, and it would increase the cost. And so we're looking at the outer years, an increase in cost of 40 cents per member per month, about the cost of a postage stamp. With that, I will be happy to answer any questions.
Mr. Hager, thank you for picking up my slack.
All right. Do we have any questions from any board members? Since this is the culmination of a recommendation coming forward to the full board for approval, and I think this is one of those times where I want to entertain more public comment on it. I know the Consumer Assistance Committee has seen this in depth, but other members may not have. So if we have any members that would like to, or any participants here that would like to offer public comment on recommendation number 3 from the Consumer Assistance Committee, now would be the time. So I will ask Ms. Johnstone, would you check and see if there's anyone there in Las Vegas?
Doesn't look like it, Madam Chair.
Okay. Is there anyone here in Carson City? Okay. And anyone on the telephone? All right.
Hi, this is Leanne Gasway from AHEP.
Okay.
Hi, Leanne Gasway from AHEP, for the record, America's Health Insurance Plans. I just wanted to note, it was stated correctly that we, as the insurer carriers, do have several concerns about the premium collection and billing process, not only the additional expense that it will add to the overall operations of the exchange moving forward in years to come, but also operational challenges that we also believe are very real. One of them also has to do with the grace period that was not mentioned in the summary issues, which is that under the new ACA requirements, there is an extensive grace period, and so a weekly reconciliation of premium payments is probably not sufficient when we have to start counting 90 days and provide appropriate notice to the enrollee when they are late with payment. So we need to address those issues in a very aggressive and assertive manner to make sure that enrollees know that they've missed a payment, that their rights need to be explained to them, and so that they can take appropriate action. Also, what was not mentioned in the summary is the fact that the tax subsidies are going to be paid directly to the health plans. They are not going to be paid through the exchange. And so all of those subsidies that are going to come for the subsidized population are not running through the exchange. They are running directly to the health plan, and the health plan has to then reconcile that with the premium payments that it's collecting. And to the extent that another party is inserted into that transaction, not only delays it, but offers an opportunity for errors and omissions to occur. So, those are very complex processes, and we just want to have everyone understand the ramifications of a decision like this, and that's fully been explained. Thank you.
Thank you. I appreciate your public comment. Any other public comment on the telephone? All right, then. I would like to ask a question then of Ms. Atkins. In this recommendation, I thought I heard either you or John state that the consumer could choose to have the billing come through the exchange or could come through the insurance company. So is this a bifurcated choice that a consumer can make?
Mr. Hager might be able to answer a little more perfectly, but yeah, and I actually just had notes in case I did the motion that yes, it's my understanding that Xerox, that we are telling Xerox to make that option available to consumers, but consumers can either choose to use the premium billing and aggregated premium billing, or they can just pay the carrier on their own. That this is just telling Xerox that they need to make this option available for consumers. Is that right, Mr. Hager?
For the record, John Hager, yes. So generally what we're saying is we are going to provide aggregated billing for individuals and families on the individual exchange by this this recommendation. Let me back up. The state or the Affordable Care Act and the regulations require that we allow an individual to pay directly to the carrier. So we have to allow them to pay the carrier directly. But for a majority of the population, if we go with this recommendation, a majority would likely pay the exchange, and we would then aggregate those bills and send them to the carriers.
Okay, but if they go through the exchange, there's an increase in cost on a per member per month basis. That's correct?
That's correct.
Okay. And I guess I don't know what the motion's going to be, but I have a concern on creating a dual role, running one through state government and the other through the private sector, that ends up having consumers being the ones that suffer the most with it. So, and I understand the aggregation part. I think that's a great way to facilitate when you've got 3 or 4 different premiums on it, but I guess I do have a concern with creating that layer at the state level rather than leaving it in the private sector where it's already established. So.
Jeff Molenkamp for the record, and I haven't been part of those discussions, but am I hearing correctly that if they're going to pay the carrier directly, that there is no aggregation? This is the only way you would aggregate multiple premiums?
For the individual market, yes.
This is Dr. Ford. I was under the understanding that the exchange has to already have billing in place for the shop exchange. Isn't that correct?
That is correct, yes.
So it'll already be in place. So it's just adding the individuals who elect that. It'll already exist, I guess, is what I'm saying.
Yes, it will already exist. The increase in cost is due to the mailing the bills out and the collection procedures that would need to be implemented, the processing that would need to occur.
Lynn Atkins, and I guess just a few more points. There is definitely the concern of multiple layers and getting the information and the premiums to the carriers and all the reconciling and the auditing. There was all of those discussions. I think at the end of the day, the overriding thought was that it was going to be easier and better for consumers who go through the exchange and have different companies or providers for their children, for their spouse, for themselves, or have vision insurance or dental insurance, that they can then select all of those items, click pay, and make one payment for all of them. I think that was the overriding principle that the folks were concerned about and that they liked about it. Understanding that, again, the devil's in the details on some of these things, and we definitely are going to have to make sure the systems are in place so the carriers get the appropriate information, they get paid. So we understood all of that. I think that's just where we landed, that it's going to be the consumer's choice to aggregate their payments to make the experience and the exchange work simpler for them.
Thank you for those comments, Ms. Atkins. Any other comments or questions by members? Dr. Klein?
Yeah, just going to say, just in terms of the cost, I mean, I think we're only considering half of the equation. I mean, we can have a long discussion about fixed and variable costs, but the exchange will have a fixed cost for having a shop exchange billing. The insurance companies have a fixed cost for having their billing processes. We will have an increase in variable costs by billing more people, and the insurance companies will have a decrease in variable costs by billing fewer people. So I think at the end of the day, it's a wash. So I think it's reasonable to say that there'll be an increase in our variable costs if we do the billing, but I think it's also fair to say that there'll be a decrease in variable costs for the insurance companies since they won't be doing that billing, and assume, hopefully, in a perfect marketplace, that translates into decreased premiums for people. 44 cents, 40 cents per member per month, as Mr. Hager said.
Thank you, Dr. Klein. Any other comments? Hearing none, is there a motion?
Lynn Atkins, I move that the board direct Xerox Healthcare LLC to offer individual premium billing function for consumers on behalf of the exchange.
I will second that motion.
All right, we have a motion and second on the floor. I'll call for the vote on it then. All those in favor?
Aye.
Aye. Aye.
Any opposed? Motion carries. Thank you.
Opposed. Madam Chair, if you can let it go on record, Leslie Johnstone's opposed.
Okay. John Stone is opposed. And Campbell's opposed on that. So we have 3 for, and 3 for the motion, 2 against. The motion passed. All right, recommendation number 4 has been, oh, let's see, I guess that's deferred till October, isn't it? Yeah, so we're going to go to plan certification. And
Madam Chair?
Yes.
We were just questioning the numbers on the last. We think maybe you totaled 7 and there's 6, or there's 6 and there's.
Oh,
it should be
2, 3, 2, 2. You're right. I'm sorry. Thank you very much. It's a vote for the motion, and 2 are opposed to the motion, and the motion carries. Thank you for correcting me on that, Ms. Atkins. I appreciate that. All right, going on to plan certification. It's under tab 8. And I think it's the second item there. So there are 3 recommendations coming before you today. The first is to allow carriers to offer qualified health plans in either or both exchanges, meaning the individual or the shop exchange, at their discretion, that the qualified health plans not be required to be identical in the individual and in the shop exchanges. With that, I'm going to do the same thing Ms. Atkins did and let Mr. Hager take the details on some of this.
So to follow along, we are on page 5 of attachment A. The plan certification and management recommendation number 3. Generally, the exchange could require that there be no difference between the qualified health plans offered in the individual and shop exchanges. The exchange could require that if a QHP is offered in the individual exchange, it must be offered in the shop exchange and vice versa. There are certain carriers that may have difficulties with this. Carriers that offer small group products only would rather only be in the shop exchange, and those carriers that offer individual products only would possibly rather be in the individual exchange only and not want to provide coverage in the other exchange. Additionally, the individual and small group markets are fairly different, and so there is concern that requiring those plans be the same could impact the the offerings in both, and so the idea would be to continue as much as it is now, letting the Affordable Care Act cause the market disruptions that are going to occur, and then later on, once we get a handle on what's going to happen, then start tweaking things. And I think that'll be the theme of all of the recommendations provided by the plan certification and also the SHOP committee, that less in the beginning, and we will take another look at these things as we get some data and review them and decide where we need to change things. A lot of the recommendations that you may see from other states are for different markets, different philosophies. We've gone with a free market facilitator model. The states that are doing the active purchaser model are very aggressively implementing regulations. And for those states that have more mature exchanges, they are offering more standardization rather than letting the Affordable Care Act do its thing and then, again, come back later. So, again, this is a matter of requiring a carrier to offer the same plans both in the SHOP exchange and the individual exchange. The recommendation from the committee was to allow carriers to offer qualified health plans in either or both exchanges at their discretion, that qualified health plans not be required to be identical in the individual and SHOP exchanges.
Thank you. And I think if I can steal some jargon from Dr. Klein, I think part of the motivation on this is to keep insurance carriers motivated to want to stay within the exchange instead of discouraging them by asking them to get into a market that they may not be in currently. So do we have any questions from any of the board members?
Ron Klein.
Yes, Dr. Klein.
John, I'm sorry, I may be having a senior moment here, but my recollection is the Plan Certification and Management Committee made this recommendation, but then I thought there was something from CSIO that overruled it, although now I can't find that written anywhere. Am I just misremembering something? Because I thought they overruled something. What's some part of this?
I don't recall any requirement from CSIO for plan certification and management. There was an item in the SHOP exchange recommendations that had to be changed because of a CSIO catch. Okay. But I don't recall anything. What
was that recommendation? I mean, I thought because it obviously affected the SHOP exchange and both exchanges. What was that recommendation that CSIO made? Can you enlighten us? Because I thought it affected this.
I don't recall. Oh, I think Mr. Bowden has an answer.
For the record, this is C.J. Bowden, Communications Officer for the Exchange. The change that CSIO had was that a qualified health plan offered on the SHOP exchange must be offered in the open metal tier, and it must be offered there. It was a requirement rather than an option. So the board voted to bring that on the open metal tier as a requirement instead of an option.
Madam Chair?
Yes, Ms. Atkins.
I have a couple of questions. So open enrollment's going to start October 1st of 2013. When will the carriers need to let us know what plans they are offering and whether they're in the individual market or the SHOP exchange? What will their deadline be, if we know, or ballpark?
Ballpark, I think, is March, April timeframe. The creation of the plans will start in the fall. The rating will probably go through January, February. The rates are submitted to the Division of Insurance, I believe, in the February, March timeframe. And at that point, I believe we'll find out which plans intend to operate in the exchange and which plans do not. They will have to have some kind of a tag on it that says that, yes, this is a qualified health plan. And that will certainly provide a very clear indication on what plans intend to go in the individual and SHOP exchanges. And then there are some testing requirements and data requirements that will have to be transferred to us during the summer. So I think around March, April timeframe, we will know who's going to play.
So in that regard, if we don't require the carriers to participate in both the individual market and the shop market. And I understand the information in the packet says that we think we're going to get enough carriers to participate in both. If we get all carriers that say we are just going to participate in shop, or if we get all carriers who say they are just going to participate in the individualized market, and we know that by April and open enrollment starts October, what can we do to fix that? I am just very concerned that we're all, getting ready, and then the carriers decide to do something different that we're not prepared for, and we are not going to have plans for individuals or the small businesses. So my thought is that we have stricter rules at the beginning, and then if everybody does come to participate in both, you can lighten up those restrictions over the course of a year or two, but that starting it so broad that the carriers can kind of go in either plan, not knowing that we're going to have enough for both plans, I'm just very worried.
For the record, John Hager, I'd say that I'm not concerned about participation in the individual market. The individual market will be opened up to 100,000 new individuals that are currently uninsured. I can't imagine there won't be at least a couple carriers that won't want to play in that market. I would say that the shop exchange is a little more concerning because they have these small employers have the options on the outside. I don't know if we could get earlier commitments from any carriers about the shop exchange, and I'm not sure, other than to change this recommendation, what to do about that if it were to happen. Whether we wait till that point, it may be too late because the rating will already be done, and maybe there's a carrier, or maybe AHIP could provide us some information on what their expectations on the shop exchange. Everybody's going to wait and see.
Somebody coming to the table right now.
Oh, great.
Hi, good afternoon. Madam Chair, Larry Hurst, representing Nevada Association of Health Plans. Just want to say thank you for all your time and effort putting together the exchange, and we want to see this work as much as you do. So there is nothing that has happened that is going to deter us from being a player in the exchange and seeing a healthier population in Nevada. So we're looking forward to working with you, and John's been great, the Commissioner, open line of communication, and working with you, the board. Looking forward to a long-lasting relationship. Here to answer any questions.
So I guess
the question we all want to know is, so among your associate members or members, what is the interest in the shop exchange versus individual? Because that's obviously the concern.
There's interest in both exchanges, equally as important in small group and individual as well.
Okay. May I ask another question, Madam Chair?
Yes, go ahead, please.
Yeah. You know, the other question besides the concern over having carriers in both was, I guess you want to call it a corollary of the churn factor that we've all talked about, is what happens when somebody has an insurance policy in a shop exchange and is laid off, quits, finds a new job, whatever, and now has to move their insurance plan. And if the plans were the same across both, then that's obviously a very easy transition. And since if they're not identical, it's potentially more problematic. So that was, I know, another concern that the Plan Certification and Management Committee had that I'm not sure we fully addressed.
Well, and Dr. Klein, I think the other thing that we discussed in that committee, too, was the fact if you force somebody into a market that they're not currently in, do you have then the opposite effect of losing them, say, in the shop if they don't play in the individual market, and having just the reverse impact that Ms. Atkins is worried about? And I'm wondering if the gentleman there that's testifying could maybe give us an idea of how large that market is, where you have somebody in the shop that deals just in shop versus dealing just in the individual market.
Thank you, Madam Chair. Again, Larry Hurst with Nevada Association of Health Plans. It's hard to say. We have those projections from John and his staff, and that's what we're looking at. So I would tend to think that someone, especially an employer, a small employer, would like to see their employees obtain coverage and benefit from tax credits or subsidies, if you will. So we would think small group exchange would be very, very popular. And in the individual market, it's up to the individual whether or not they want to play in the exchange. Getting the subsidies should be an enticement. We're just hoping that the small penalty for not getting insurance is not a deterrent from accessing health care services.
Any other questions from board members or even from our non-voting board members? Ms. Atkins?
Lynn Atkins, I have another question. Did any of the carriers talk or offer public comment at the committee meeting that we could get some sense? I mean, I think both, Madam Chair, I think you're right. I mean, I think there's the concern both ends. If you don't require them to play in both markets, then yeah, I can see that there's a concern that no one will come to the party. But if you also give the option that they can participate in whichever market, if everyone chooses one market, the other market fails. And so I think I agree there's definitely that concern. I think some of these recommendations are just too broad, that they can, at their own discretion, they can participate in either exchange. There's no set limit on the number of qualified health plans that they're offered. I think I guess I look at this as there's not really a framework that's been developed. And so that's my concern.
Madam Chair, if I could answer that question through you to Ms. Atkins. There's a couple of health plans in the state of Nevada that don't participate in the individual market. They have strictly group plans. So if we mandated all health plans to play in both exchanges, it would exclude two health plans. I'm just thinking out loud that could possibly be an issue. Thank you.
And Ms. Atkins, that was part of the conversation that came up in the plan certification meetings, is that we were going to take an approach to encourage people to participate rather than try and restrict this new marketplace, because nobody has that crystal ball just yet. Nor I'm not sure we'll ever get that crystal ball. But what we wanted to do is let the market play it out the way that the market felt that it wanted to participate in it, rather than trying to dictate to them who should be in the exchange and who should not be in the exchange. Your questions are valid. I mean, all of us have those concerns. If you get just the shop participants, if you just get the individual market participants, if you told them they had to have both, would you have 0 participants?
Can I ask you a question? John, maybe you can walk me through this. What happens if somebody is in the shop exchange, they leave their job for whatever reason, and now they want to go into the individual market? So they're going to transition from shop to individual market. They have a policy in the shop exchange with a carrier that doesn't work on the individual market. What happens to them step by step, day by day? If there's no open enrollment period, what exactly goes on in your mind?
For the record, John Hager, it depends on a lot of different things. So for an individual, no family, they lose their job, they will be offered COBRA coverage under the current rules. Obviously, COBRA is unsubsidized, would cost a lot more. Because they have no income, they would be eligible for subsidized coverage through the advanced premium tax credit as a loss of coverage event. So that's one way. The other way is they could have a spouse that has coverage through their employer, and they could come on to their spouse's coverage as a dependent due to a loss of coverage event. And that could be through the individual exchange, it could be through the shop exchange, or it could be through the employer's, that person's employer's coverage outside of the exchange, and that person will be covered through that. If you have I think possibly what you're getting at is a person is on a plan that is not offered, they're on a plan in the shop exchange, and it's not offered in the individual market, if they end up in an individual plan, they would have to, at that point, choose a new plan as a qualifying event for a loss of coverage event due to change in income status. The same is true going from the individual market to the shop exchange, or going from an employer that's not on the exchange to if an employer is not on the exchange and that person loses their job, they would have the same options. They would have to find other coverage, or they go on COBRA coverage. So it's the same issue whether it's on the shop exchange or outside the exchange. You could potentially minimize churn by requiring the same plans on the shop and individual exchange. However, going from individual coverage to the employer coverage, you will likely have a change, because whether or not the employer has chosen the options that the plan that the individual had, that could be different as well. So there's a lot of different scenarios that could play out. I hope that answers your question, sort of.
Madam Chair, if you wouldn't mind indulging me one more moment, I guess I'm also thinking that we're trying to have more choice for the consumer. And maybe everyone here will tell me that no, we're not trying to do that. But we're trying to. The Affordable Care Act is trying to do something different and trying to make sure more people have health insurance. So I'm just trying to imagine the possibility that if we do require carriers to play in both the individual exchange and the shop exchange, that no one will come. I'm trying to figure that out, that the carriers that do provide individual coverage, that they'll say, well, no, I'm not going to provide small business coverage, so I'm going to get out of the insurance market in Nevada. I mean, is that really the dialogue here? We really think that's going to happen?
No, I think the choice would be, do I want to be in the exchange market? You know, if the exchange tells me I have to play in the shop market and the individual market in order to play in the exchange sandbox, am I going to be telling some carriers, because they're not in one of those markets, that they're excluded from participating here? And I think that was the downside that we were looking at, because I think one of the goals is to create an exchange that has options within it instead of only one or two carriers. You want to have a variety of different products in there for consumers to choose from. And I think if we get it too restricted, you may have too few participants, you know, from the carrier side. And I don't think there's any perfect choice to this, but I think we need to get started somewhere. I think our feeling was it was easier to keep it broader and open and then start to restrict it as we see how it's playing out, rather than doing the opposite.
Madam Chair, can I ask a question, perhaps maybe more to John? John, you were saying that the plans will start submitting their proposals to the Department of Insurance in fall of this year, meaning a month or two from now. Is that, did I hear you correctly?
No, they will start creating their plans, and in the fall do the rate review, create the rates probably in January timeframe, and then start submitting those in February, March timeframe.
So 3 months from now, I mean, obviously the concern, which is theoretical but real, is that you have nobody in one and everybody in the other. But we'll know that answer in January, because you either will have plans submitted or you won't. Is that a correct statement?
I think we'll know that in February or March.
Okay. And so let's assume the worst happens, and everybody's in an individual market and nobody's in the shop exchange. What can we do in March to remedy that for 9 months down the road? Can we then change our recommendation and say, no, you have to offer? I mean, what happens if the worst happens?
For the record, John Hager, you know, I'm not sure. It's difficult to say what how that would play out and what we could do. If it's hard to say now. let's say the worst happens and nobody participates in the shop exchange. There's still a small group market where employers can get their coverage. And I'd hate to say that the shop exchange would start a year later, and we'd have to figure out how to make it work and start the ignition again. So I suppose the worst case scenario is if we can't change anything and there's no players in the shop exchange, we start the shop a year earlier. There is still coverage available to small employers. They just don't have the same options that they would have otherwise. I would have to think about what we could do. I'd have to get with the Division of Insurance to think about what we could do if we don't get those players, if we don't have that information by February, March.
Let me ask a technical question, and I don't know if our Deputy Attorney General will know this. Is there a process that the exchange and the Division of Insurance could require a pre-registration to be done by, say, December 1st, just kind of like a letter of intent or something that we intend to proceed down this path based on the rules that we see in place right now, instead of making it a guessing game until February?
I don't, well, I mean, this is all new, so there certainly isn't any specific regulation or statute that that allows or requires a letter of intent, and certainly even if they say they intend to participate in one or two of the exchanges, that could change. So I don't think that there's anything that we can do short of being an active purchaser and actually contracting with somebody. We could, perhaps it might make sense to get through all of the recommendations and get into, say, December and say, okay, we've pretty much made all the policy decisions. Are you going to participate or not? And we could get, I mean, it may be an informal poll, but we could get an idea of how much participation we expect to get in the shop and individual exchange.
The other thing we could do would be to table this recommendation till Tuesday and have you do a quick poll, or have somebody do a quick poll of the insurance companies in Nevada to reassure us. Because I think if you came back to us 5 days from now, and I appreciate that there's an interest in moving things forward, but if you came back to us 5 days from now and said, all right, I've talked to the 10 insurance companies in Nevada and 9 of them are interested in the shop exchange and they're going to do it, so don't worry. I think we'd feel differently than where we're sitting now. So it might be worth tabling this and reassessing on Tuesday.
So a couple
Madam
of
Chair, this is Leslie. I would just have a question. You know, what were the carriers' reaction during the committee meeting to these different recommendations? I mean, that's the opportunity to hear that this is a big problem and we're not going to play if you do this. That's why we've gone through these hearing processes.
No, and I think the industry reaction was that this was a favorable direction to take. And Dr. Klein sat through the meetings like I did. He may have taken the, the participation or lack of participation differently than I did.
No, the answer was that they didn't want us to, as any business, they didn't want us to restrict what they wanted to do. They want to do what they want to do. But that doesn't answer the question. We didn't hear, to the best of my recollection, anybody say, oh, yeah, we're all going to be participating in both. We heard none of that to one direction or the other. What we heard was don't restrict us.
I appreciate that. I would be doubtful we'd get anything more definitive about that between now and next Tuesday. So I would say to go ahead and move forward with our action on the recommendation.
If I might add one thing, so first of all, we're past the posting deadline for Tuesday, so Tuesday's out. We could bring it back to October. However, I don't think that without having the full packet of recommendations approved by the board, I don't think we'll get an answer from the carriers. They are pretty much waiting, and they've got the wait and see approach right now. It might make sense to go ahead with the recommendations or make the recommendations one way or another, and get through this process and then revisit it in maybe November once we've got a more full set of recommendations and the carriers are more comfortable with what we've done. If in fact we get a response that no, we're not going to participate in the shop exchange, we can revisit these items if we need to.
Any other questions or comments? What is the pleasure of the board then?
This is Leslie Johnstone. I'll move approval on the recommendation.
Thank you.
This is Dr. Ford. I second.
All right, thank you. We've got a motion and second on the floor on this. All those in favor of the motion?
Aye.
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 Aye. Are there any opposing?
Nay, Lynn Atkins.
Okay, Lynn is. All right, so we have 5 for the motion and 1 opposed to the motion, and so the motion carries. Thank you. The next item under plan certification is recommendation number 4, to allow carriers to create qualified health plans that meet the requirements of the Affordable Care Act, that the exchange not impose any additional cost-sharing requirements on the qualified health plans. And that's, you can tell us the tab number. I've got paper copies. I think some people are working off computers.
So we're on page 5 of the PDF of item attachment A. So the cost-sharing standardization, the idea was brought forward that we look at standardizing copays, coinsurance, and deductibles. Right now, the way the Affordable Care Act is contemplated, the standardization occurs through the creation of the metal tiers, where a bronze plan is equal to about 60%, or the bronze plan has an actual value of 60%, which means that the plan will pay on average 60% of the costs, and the individual will pay the other 40% through deductibles, coinsurance, and copays. For silver, it's a 70-30 split. For gold, it's 80-20, and for platinum, it's 90-10. So the idea was, I think the idea for the Affordable Care Act was that we try to standardize these. We have a better understanding of comparing apples to apples, a bronze plan to a bronze plan or a gold plan to a gold plan, so you know where you're at, and you don't have these hidden cost-sharing items. Some states are moving toward a standardized cost-sharing. So right now, the way it is, if we don't do a standardized cost-sharing, the carriers will have access to a premium calculator that uses a national set of data from SSHIX CMS. They will enter their information, their copays, deductibles, and coinsurance till they reach that actuarial value plus or minus 2%. What the exchange could do is do that process for them, basically create an actuarial value or use an actuarial value, create the deductibles and coinsurance and copays to meet that actuarial value, and then require that all the plans meet those requirements in their qualified health plans. There's a couple ways you can do it. You can either standardize all of it. You can require that each carrier offer a standard plan, and if they offer a standard plan in a tier, then they can offer whatever else they want, or you can let them meet the actuarial value requirements as they see fit. I guess the best example of a state that is doing the standardization of out-of-pocket costs is Massachusetts. One of the main differences, of course, is Massachusetts is a mature exchange. They've been doing this for about 5 or 6 years, and they don't have the actuarial values yet. So they are standardizing or have standardized copays, coinsurance, and deductibles because they don't have the actuarial value standardization. So I believe the recommendation was to allow carriers to create qualified health plans that meet the requirements of the Affordable Care Act, that the exchange not impose any additional cost-sharing requirements on the qualified health plans. And in the notes, you'll see that that we expect to come and revisit this recommendation, and I think we should probably revisit all of these recommendations at some point after at least the open enrollment period in 2014, but probably into 2015 once we get some data on where everything stands. Again, the recommendation is for less regulation and to consider tightening it up later. One of the arguments for doing the standardized cost sharing is it is supposed to make more sense. It's supposed to be simpler for the consumer that is trying to purchase insurance. What we have tried to do, and you saw that in the Xerox web demo, is to provide a cost calculator that helps it helps the individuals figure that out by plan. We think that we have mitigated the requirement that you have absolute cost sharing standardization through the cost calculator and the way it's displayed on the web portal. But I guess that's up for the board to decide. So with that, again, the recommendation is to allow carriers to create the qualified health plans that meet the actuarial metal tiers in the Affordable Care Act and not impose any additional cost sharing.
I'll open that recommendation up to questions or comments then. Any questions out of Las Vegas?
Okay, Ron Klein. I will speak for the group down here. We have no idea what you just said, John. Can you want to try that one more time?
I think the cost calculator is going to make it all clear.
You want to try that again? And I was serious. You want to try that again, like in seventh grade language or something?
So right now, you go to purchase insurance, and you have the average person has no idea how to compare deductibles, coinsurance, and copays. It's going to be even more difficult for people that are currently uninsured. Again, we do have the cost calculator in the web portal that should make it simpler for people to check prices and compare prices. One of the other ways to help people understand the differences between plans is to make them as similar as possible, to standardize coinsurance, copays, and deductibles. So we'll say, all right, a silver plan has a $1,500 deductible. No matter what plan it is, they have a $1,500 deductible, 20% coinsurance, and $20 copays, and everybody has to do that. We could either require that and make sure that we set that to meet the silver plan requirements, or we can tell the carriers, you go out and meet the silver plan requirements. And what that will mean is when a person goes to the web portal, they might see two plans in the silver tier, one with a $1,500 deductible and one with a $1,700 deductible, but one will have a different copay on it. So the idea behind the idea of standardization is that the cost sharing is identical for all the plans, or at least a set of plans in each tier. The recommendation was to allow the carriers to set the deductibles, coinsurance, and copays as they see fit. And if I recall on this one, there actually was quite a bit of carrier involvement. They were strongly opposed to setting a standard set of benefits. Again, Massachusetts is setting a standard set of benefits, or has done that, but the actuarial value requirement, that standard, doesn't take place until 2014, and I'm not sure what they're going to do once 2014 hits, if they're going to take away that standard cost sharing and just allow plans to meet the requirements of the Affordable Care Act. Was that maybe a little simpler?
Thank you for making that simpler. So is it your assessment that the cost calculator on the web portal will allow people to understand this better? I obviously there's a lot of political philosophy here in terms of restrictive versus non-restrictive, and I appreciate the non-restrictive element as long as consumers are informed. So is it your thought, having spent a lot of time with the Xerox folks, that at the end of the day, given all these different plans and ways of getting to a metal tier, that a person will be able to pick a plan and have their calculator say this is what it'll cost will be? Because I remember seeing that on the demonstration. So you feel comfortable that it'll do that?
I think so. I mean, there is going to be a lot of confusion about deductibles, coinsurance, and copays, whether we standardize them or not. You have a huge population of people that don't have insurance and traditionally don't have insurance, whether it's because it's not affordable or they just honestly don't believe in insurance. They think they should just pay the doctor when they get there, whatever the cost is. So there will be a large portion of the population that does not understand deductible, coinsurance, and copays, regardless of whether we standardize it or not. The the cost calculator should provide a good estimate. One of the notes I have written down from the demo is that we have to have a big old disclaimer on there that says this is, based on your input and this is close. But I think it will get a person to their total out-of-pocket costs a lot more accurately than simply looking at the plans and understanding themselves. Now, that said, we will have the brokers and the navigators, assuming that the plan is approved by the board in October, assisting individuals enroll and understand their coverage. We also have funds set aside for the outreach specialists, funds set aside for for outreach with the tribes, and we have funds set aside for GovChaw. So there are quite a few avenues for individuals to understand their insurance better.
Just a quick question, because once again, I was involved in some of these discussions. Are we only talking cost components then, the premiums, the deductibles, copays, or does this include what's covered under the plan as being different?
There's a whole other discussion about what's covered. This is just cost sharing. It's not premium. It is only coinsurance, deductibles, and copays, the out-of-pocket costs after you've paid your premium.
Lavon Lewis, one question.
Yes, Ms.
Madam
Lewis.
Chairman.
Yes.
Will the premium calculator, I think that's what it's called, also be able to, will the consumer be able to determine what their actual cost is going to be from looking at that? And I don't mean actual to the penny, but I mean a good estimate in terms of comparison to another plan.
Generally, yes. So what the web demo showed was that you would be able to enter if you expect to have a procedure, how many times you expect to go to the doctor or a specialist, and then your estimated drug spend, branded generic, I think. It's still a broad estimate. There are obviously costs that will be wildly different at times, but you put in that basic information, and it populates your out-of-pocket costs. It takes the premium plus those deductible coinsurance and copays that you would pay for that year, and it shows them for each plan that's there. So you can set one set of inputs and get the full cost to the individual for each plan that is available under that tier that you've selected.
Lavon Lewis again. So it's going to work kind of like the Medicare people use to determine what's the best plan for them if they're looking to get something outside of Medicare? I mean, does it work kind of like that?
Yes, it does.
Okay, thank you.
Lynn Atkins, just one question or comment, Madam Chair. I like having all the consumers to have all the choice. I just want to go back to the capacity issue that we're talking about, the calculators and people needing help understanding the difference between a premium and a deductible and the copay, that if we're talking 100,000 new people between the 6-month period, most who have never had insurance before, there's going to be a lot of questions, a lot of help me figure this out, and I don't, and the calculator is going to be great for some people, but I think we're going to have a lot of people who are going to need a lot more assistance than that, and I know I've expressed my concern to Mr. Hager that there's not enough in the budget for outreach specialists and navigators to help the consumers get through this. But I do like all the choice, and I'm glad we're talking about this.
Ms. Hickens, I would totally agree with you. I mean, the marketing that we're going to need to do and the educational process that needs to take place, I think is going to be enormous. I think that there are still so many misconceptions about what the exchange does. Occasionally, I run into people that think there will be no premiums. I mean, it's just amazing the lack of knowledge that a lot of people have about the process that we're going through. So I couldn't agree with you more. Any other questions or comments? What is the pleasure of the board on recommendation number 4 then? Since I was on the committee, and I guess it's okay, I'll move approval unless, Dr. Klein, if you want to do it, that's fine too.
I'd be honored to second your motion, Madam Chair.
Thank you.
Madam Chair?
Yes.
Hina Rasul, Senior Deputy Attorney for the record. Typically, chairs do not make motions.
Okay, thank you.
Then I would like to make a motion that we approve recommendation 4, to allow carriers to create QHPs that meet the requirements of the Affordable Care Act, that the exchange not impose any additional cost-sharing requirements on QHPs.
Thank you. Since I won't,
This is Dr. Ford. I'd like to second. Thank you.
thank you, and I removed my comments. Thank you. John kept saying, it's your committee, come on. Anyway, we have a motion and second on the floor to approve recommendation number 4 out of the Plan Certification Committee. All those in favor of the motion?
Aye.
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 Any opposed? The motion passes unanimously on this one. Thank you. There is one last recommendation coming out of this committee, and at the end of that...
Madam Chair?
Yes?
Oh, there was just a request for a break.
You know what? If you want to do it now, it's fine. We'll take a break now and then come back for recommendation number 5. I was going to do it after that, but now is fine as well. We will come back on the record at 3 o'clock. It's about 8 of 3 right now. All right, let's get back on the record here. We've got, again, I just want to reiterate to everyone, we have to be out of here by 4:30 today, or else they'll close us down. Anyway, do we have everybody back in Las Vegas ready to go?
Yes, Madam Chair.
Thank you. Then let's move on to the last recommendation coming out of Plan Certification and Management, which is recommendation number 5, and that is the exchange set no limit on the number of qualified health plans offered in the exchange.
So there's, again, a debate on whether or not carriers will try to flood the exchange market with as many products as possible to get as much market share as possible, or whether they'll self-regulate and not create any more plans than they need to. So if no limit is created, there's a potential to flood the exchange. However, we think that carriers will generally self-regulate, will limit themselves, limit the number of plans they offer because of the additional expenses associated with rate review, certification, licensing, etc. Furthermore, the web portal can be designed so that a random plan is displayed first on the line, so that no single plan has an advantage based on its position and on the list that the consumer sees. So we could create the portal so that we randomly select a carrier, and then one of their plans is first, and then we randomly select a second carrier, and one of their plans is second. And that process could change each time an individual goes to the web portal. And so with that, it's a very simple recommendation that the exchange set no limit on the number of qualified health plans offered in the exchange.
And again, I think philosophically this goes back to the fundamental thoughts under recommendation 3 and 4 is that we let the market kind of determine who wants to play in the exchange and who does not. That being said, I do want to reiterate one thing that I think Dr. Klein will remember as well, is that in any and all of these recommendations, it's the intent that we bring these back for review in 18, 24 months or whatever that appropriate time frame is, so that once we see how the exchange is starting to function, that we can monitor and either restrict as needed or just feel that we've done the right job right out of the box on it. So do we have any questions on that recommendation?
Madam Chair, Lynn Atkins.
Yes, please.
Probably for the reasons I stated when we were debating number 3. Again, I just believe that this is not a framework, and that I would suggest that we set some number, whether it be 5, whether it be 10, I'm not sure what that number should be, but that we do set a number so we have some sort of control over the number of plans. It's just going to be too hard for consumers to compare and contrast the very small differences that could come up in some of these plans, and I just do not believe that is in the interest of the consumer or the exchange.
Ron Klein, I would second what Ms. Atkins said. I think especially since we just approved recommendation 4, which allows them pretty much, the carriers, to do whatever they want in terms of meeting the actuarial requirements. If we have an unlimited number of plans with unlimited variables, I think it creates more confusion. So along with that whole issue of a lot of people coming into the plan, 100,000 people, which my quick calculator tells me it's 555 a day for 180 days, who don't have experience in the market, don't know, as Mr. Hager said, what co-insurance is, what deductibles are, that having a large number of plans will make a bad situation worse. So I don't know what the right number is, but I think we should probably think about a number and maybe, you know, our philosophy has been to not regulate things and then decide we're going to regulate them if there's a problem. And maybe in this situation, coming from the other end might be better to put some kind of reasonable limit there. And if things go smoother than we want, or smoother than we hope, I'm not saying that right, if things go as smoothly as we want, as we hope, then perhaps increase the number, but perhaps put some reasonable limit now to minimize confusion.
Madam Chair, this is Leslie Johnstone.
Yes, Ms. Johnstone.
ask a question, I guess. You know, on the earlier recommendation, if the worst occurred, we didn't have any options to regroup and go out and get new policies or carrier interest. In this one, if the worst occurs and we get way too many plans put in front of us, what are the pros and cons? And I would ask either Mr. Kipper or Mr. Hager, what are the pros and cons on in February regrouping and saying this is more than we expected, let's figure out a way to cut it off, because right now nobody's going to know what a magic answer is.
For the record, John Hager, in this instance, I think it would be much easier to make a change in February. You're not requiring the carriers to add products; you're asking them to take products away that we're offering. So once we have a better idea of how many products in each tier, if we feel like it's overload, we could ask the carriers to maybe select their top 2 or top 3 in each tier or something like that, and not offer the other ones. Again, it's up to that policy decision is up to all of you.
And again, I guess I would have a question, John. If we were going to set a limit, is each metal tier a qualified health plan by itself?
When a carrier provides a qualified health plan, it must be at one metal tier. So if they want to provide a plan at a silver tier and at a gold tier, that's 2 qualified health plans.
That's what I was saying. So if you had a carrier that wanted to offer at every tier, that's 5 plans.
Correct. With the catastrophic plan, it's 5 plans. You could decide to limit the total number of qualified health plans that a carrier offers, or you could choose to limit the number of plans that are offered at a given tier. Maybe you make it 2 plans per carrier per tier, or 3 plans per carrier per tier. I don't know. Depending on how much interest we have. If we have interest from 18 carriers, that could obviously be quite a few plans. If we have interest from 3 carriers, then that gives you 6 or 9 plans.
And Lynn Atkins, so under the current recommendation, carriers can submit 20 plans in the silver category, 20 plans in the gold category. I mean, that's the way it's being proposed and the way the committee came out. Is that right?
Ms. Atkins, I think probably a broad question of that nature came forward, and the carriers and the advisory members that represent some of these carriers all felt that nobody was going to try and mass market that exchange area in that manner. So, and I think our decision at that time was a unanimous one to let them put as many in as you wanted. We can always put restrictions around it. I hope we have a problem that we have way too many carriers in there. I think most of us are of the opinion we're afraid we're not going to have enough options within it. So again, for the same reasons that we offered the broader contents on recommendation 3, we're doing the same thing here with recommendation 5. You know, if there is a concern that there's going to be a flooding of the market with one particular carrier, we could offer a caveat to this recommendation that it be reviewed, say, in February or so to make sure that there isn't a flooding of the market.
Madam Chair, if there aren't any other comments, I'm ready to make a motion.
Yes, Ms. Johnstone.
I would move that we move forward with this recommendation with one addition, that we revisit this in February and at that time identify whether or not we have more plans submitted than what we're comfortable with, and be able to modify it for the 2014 year if we deem necessary at that time.
Is there a member that wishes to offer a second to that motion? Okay, hearing none. Oh.
This is Dr. Ford. I second.
Okay, thank you, Dr. Ford. All right, we have a motion and a second to adopt the recommendation from the committee with one addition to that recommendation, that in February, staff brings back to us a monitoring of how many carriers are coming into that market, so that we don't create, I guess, for lack of a better word, a monopoly of one carrier within the exchange. So,
Madam Chair, will there be discussion?
Yes, go ahead.
Mr. Hager, from the dates you gave earlier, it doesn't sound like we'll really know in February. Is that correct?
We may know in February. It might be as late as March. It's difficult to say exactly when. We could start doing straw polls, I think, in December, maybe as early as November, but certainly in December on what carriers' plans are.
Thank you for that. I'm just letting the group know I'm going to be opposing this as well. I just, again, think that there's understanding that, yes, we can review this in February, March, or April to kind of see how everything is going. I think this doesn't force the carriers to kind of put forth their best, most competitive plans for the consumers, and that and who's going to be going through all of these, and then we're going to be decide. I don't know. I just think that we should be selecting some sort of number in each tier, again, to have a framework that we can work from.
May I ask a question? Ron Klein. Maybe a question to Mr. Hager, to Mr. Kipper, or to the AG, Deputy AG. Are we within our legal bounds if we have too many plans in February or March to then change the rules midstream and say there are too many plans, we're now going to change, or have we done something illegal at that point? Because I guess I could see if I were a carrier and I went through the process of submitting 20 plans, and then in March the exchange changes the rules and says, oh, sorry, pick your best 5, I could see that might cause legal problems. So I guess I appreciate the motion and just want to be clear that we're within legal rules in doing that.
Well, since we have no regulations yet, I suppose that depends on how we set those regulations in the November, December, January timeframe. I don't think that I don't think the law contemplates this issue right now because this is all brand new and it's all in the implementation phase.
We have Deputy AG that's going to give us some comments.
I would, for the record, Hina Rasul, Senior Deputy Attorney General, I would agree with John. At this point, there are no regulations. And from what I understand, the motion to be is that you would just simply revisit. You're not restricting. Am I correct? So to revisit the matter based on new information, I don't think that would necessarily be something that would be not allowable.
LaVon Lewis, Madam Chair, but I think that the purpose of the revisiting could be to restrict if there were too many plans, or if we felt there were too many plans, depending on how we defined too many. But that the purpose could be to restrict.
And that
at the revisiting time.
Thank you. I believe it's at this time to make that motion would be okay. However, I would recommend that we have our office look into the issue and provide you an answer of whether or not it actually can be done, or what the repercussions of doing so would be at the next meeting.
This is Ron Klein. I would love to hear Mr. Kipper's opinion on this matter.
Mr. Kipper left, but we do have someone here from the Division of Insurance that might be able to help us.
For the record, Adam Plain, Nevada Division of Insurance. I'm not an attorney. I don't know that I'm qualified to actually offer an opinion on the specific question. So I'll forgive me if I kind of skirt around that. But I think to address the concern, when an insurer files rates with the division for a product and creates that product and plan, there's operational costs associated with that to the insurer. And personally, there is some doubt in my mind that an insurer would flood the market with rate filings, knowing that they're going to have those sunk operational costs associated with it. In the insurance world, another insurance product like bail bonds, you have a list of bail insurers or bail agents, and there may be some tactical advantage, for lack of a better word, to having your name on the list 16 times as opposed to 6 times. But in the health insurance market, I'm not sure that advantage exists. To compound that a little bit more, if an insurer is going to have multiple products filed, there has to be some technical difference between the products. And if that technical difference is associated with the coverages offered, the more products you have, the more specific each product becomes, and the more subject to adverse selection each product becomes. So instead of having 3 products that have general coverages, if you offer 20 products and the differences are very technical, you might find that your utilization ratio on a particular product changes adversely, and it becomes a money loss for you. Then the product next to it has a different set of ratios. You get adverse selection in that one, you lose money on that one, and it just kind of cascades down the line. So, like I said, I think that kind of skirted your legal question, but maybe addressed the more technical aspect.
Would the board object to, if Mr. Hurst is still there, who represents the industry, maybe he might address this issue for us?
Thank you, Madam Chair. Again, for the record, Larry Hurst, Nevada Association of Health Plans. And I have a team, all of us members, we have teams of actuaries and plan design professionals just waiting for the qualified health plan, the benchmark plan, and the essential health benefits, and then we're off to the races. We're excited to get our products put together and filed with the Division of Insurance. So we're looking forward to that as soon as possible. So I guess next week, then we'll get started.
Can I ask a question? If we wanted to pick a generous number of plans per insurance company per tier, so that we wanted to be not very restrictive, but put some reasonable limit on that, what number would that be?
And for the record, Larry Hurst of Nevada Association of Health Plans, we certainly would not want to flood the exchange because it wouldn't make any sense to compete against our own product. I'm thinking definitely 1, perhaps at the most 2.
So if we had a motion that said we are happy to have for each insurance company maximum of 3 plans per tier, so 15 plans, would that be a pretty reasonable place to be?
For the record, Larry Hurst of Nevada Association of Health Plans, I believe that would be fair, and we have to offer so many by tier. So again, we don't want to compete against our own plan design, but
3.
We have
4.
Madam Chair, if somebody wants to amend the motion, does it need to be the person who made the motion, or can it be anybody?
If I may, it would have to be the person who made the motion, and then the same person who seconded it would have to second it.
And before we do that, we have Dr. Ash Jackson here that is wanted to make a comment on this, and she also served on the Plan Certification Committee and might be able to help us a little bit here.
Thank you, Madam Chairman. Linda Ash Jackson from Hometown Health. If I can give you we have 3,800 plans, of which we sell 210. So what we have found that specific customers like certain features on some of the plans, and they literally plan which ones they're going to buy depending upon whether or not they're comfortable with a large deductible. They want to know whether or not they have a fixed emergency room cost or they have a copayment for outpatient surgery. So if I had to say what would be the minimum number for the tiers, I would say we would need to have something that would be to offer a plan that allowed us to provide co-payments for services in a PPO environment like outpatient surgery where they weren't worried about large deductibles. Some people are going to not worry about the deductibles because they're going to bet that they're not going to be sick. So they may, in fact, want to take the risk on the large deductible. That's a traditional PPO. And some people will want very close to first dollar coverage, depending upon the tier, and then they would want an HMO. The next thing that would happen is that some people will want what they call a point of service plan that has first dollar coverage within a network, but then a deductible and coinsurance outside the network. And that, in fact, is what is part of the #1 small group plan in the state, which is that Sierra plan. So I would be not comfortable, and I'm going to jump and speak for at least for Hometown and probably the industry, restricting it to any less than 4 or 5, because I think that's what will meet the public's need based on how they're comfortable with how their family has used care.
Can you just restate that when you say 4 or 5 per tier, or just 4 or 5?
4 or 5 per tier. And I know that seems like it's very confusing, but that's when we go into a group and we offer them multiple options, that is where the group is very specific about how, including the small group, how they expect to use services and what is more important to the members of the group. So I'm going to assume that that same decision-making process will continue both in the shop and in the individual exchange. And I know that every carrier would want to be able to meet the needs within each tier.
Sold.
Dr. Jackson, is that coming from a group or individual perspective?
That's coming from a small group perspective.
Okay.
Because we currently don't have an individual plan. But I can tell you that I have reviewed all the individual plans in the marketplace since Hometown's thinking about getting into the individual marketplace. And very specifically, there are the same model that there are some plans that offer co-payments and some plans that offer deductibles and coinsurances depending upon the expense of the plan. So I'm comfortable saying that I would think that the market might behave fairly similarly.
Madam Chair?
Klein? Yes.
This is Leslie Johnstone. As the maker of the motion, I'd be willing to put forward an amendment to that motion.
Yes.
Which would be to limit the number of qualified health plans put forward by any one carrier to no more than 5 per metal tier, and that would be per market, so both in the shop and the individual.
I second this, Dr. Ford.
Okay, so we have the maker of the first motion has amended, and the seconder has approved that amendment to the motion. Let me see if I can restate this, Ms. Johnstone. So the recommendation will be to limit the number of qualified health plans to issued by each carrier to no more than 5 per metal tier per market, meaning, the shop and the individual market will be considered separately. Is that?
That's correct.
Okay. Do we have any further discussion on this item? Yes, we have the Division of Insurance coming forward.
For the record, Adam Plain, Nevada Division of Insurance. Sorry that I didn't ask this before, but it would probably be helpful for the board to define how you want to use carrier. In that, in the insurance world, it's not uncommon for multiple licensed insurers to exist as a holding group, and so you should, but operate under the same trade name. So you should probably define, if you're going to impose limits, how you want those limits imposed on insurers in such a fashion.
Do you have a recommendation?
Probably
Madam
not.
Chair,
No.
this is Leslie Johnstone. I think the intent is trade name because we're trying to get at what the consumer is going to see. And so I would say trade name.
So for instance, is United and HPN down here in Southern Nevada, are those two different companies or is that one company in terms of trade name? Those are two different companies? Yes? Yes, I'm hearing yes. Okay, so United, in terms of stock, whatever, ownership, United then can offer 10 different plans per tier, 5 for United, 5 for HPN. 5 for Sierra, 5 for United, yeah.
Dr. Klein, we're hearing what you're saying. We can't hear what somebody's responding to you. So could you, just so the record's clear?
Sure, sorry about that. The response from a gentleman in a lovely suit and tie, and he looks like he's like a well-dressed insurance person, is that United and Sierra Health would be two separate companies for the purposes of that. So that they could choose, so that United could choose 5 and Sierra Health and Life could do 5. So for the purposes of that, those are two separate companies.
Okay, I'm going to restate it differently just so we make sure that everybody. So if you have a holding company that has several subsidiaries or affiliates, each one of the subsidiaries and affiliates would be considered to be its own entity. Does that make sense?
We're nodding yes, Madam Chair.
Okay, good. I just want to make sure we're all on the same page. Thank you very much. All right, is there any further comment on this recommendation? Hearing none, then I'll call for the vote. All those in favor of the amended recommendation?
Aye.
Any opposed? Motion carries unanimously. Thank you very much. All right, let me just check with John here because we came out of sequence here and see where we're going from here. All right, now we're going back over to SHOP, which is subsection D on the agenda item number 8.
So the committee chair for the SHOP exchange is Ms. Kerr, who's not here, and I did not have an opportunity to call Dr. Ford up, who's the vice chair. Did you want to make any comments on these, Dr. Ford, or would you like me to go forward with them?
You can go ahead. Thank you.
So recommendation number 2 for the SHOP exchange is in regards to merging the individual and small group markets. So basically, right now we have the option to merge the 2 to 50 employee market with the 51 to 100 employee market. Right now, they are separate. The Affordable Care Act allows you to merge those markets starting in 2014, and it requires that those markets be merged in 2016. The market characteristics of the two groups are fairly different, which is why they are categorized separately, although again they will have to be merged in 2016. Typically the states that are merging the markets have one of those markets a lot smaller than the other. So, for instance, the individual market, say, is 5 or 10% the size of the small group market, or vice versa. When you do that, typically, when you have that situation, typically the very small market, let's say it's a small group market, or the individual market is 10% the size of the small group market. You have a small population of individuals. Because you have a small population, rates are very volatile and can often be very expensive. People are not going to that individual market for a reason. They're getting their coverage elsewhere. And so when you combine those markets, because it's such a small group, you end up reducing the volatility of that small group and typically the cost of that small group without having much impact on the other market, because that other market is so much bigger, it can absorb that market fairly well. In the case of Nevada, the markets are fairly close in size, and I believe it's 66,000 members in the 2 to 50 employee market and 38,000 subscribers in the 51 to 100 group market, so it's 33%. I'm sorry, that was incorrect. 66,000 members in the small group market and 105,000 members in the individual market. So when you combine those two markets, you will likely see a big increase in premiums for one and a decrease in premiums for the other. The report that we received from, I believe it was Gorman Actuarial, indicated that the morbidity of the small group market was higher than the individual market, and that rates would be rates in the small group market, all things being equal, would be a lot higher in the small group market. And when you merge those, the small group market would come down and the individual market would come up. Many of the carriers strongly opposed that. They felt it was exactly the opposite. But again, getting back to that ratio issue, it is very likely that no matter how you, whichever theory you subscribe to, there will likely be a large change in both markets, up and down, and it doesn't seem to really benefit the market currently to merge those markets. Now, we are required to merge them in 2016, but again, going with the philosophy of let's wait and see what the Affordable Care Act does, we recommend that we delay that. Additionally, this is a market-wide issue, so you can't just merge it in the exchange. You'd actually have to merge the entire market, which is more of a Division of Insurance issue. So it'd be, if anything, it would be a recommendation to the Division of Insurance, and it would be some pretty substantial changes to statute. Again, the committee recommended that the individual and small group markets remain separate, and the small group, 20-50 employees, and mid-sized group, 51 to 100 employees, remain separate until they're required to be merged in 2016 by the Affordable Care Act. With that, I'll be happy to take any questions on that recommendation.
Any questions from board members? If there are no questions or comments, do any of the members want to make a motion?
Madam Chair, this is Leslie Johnstone. I'll move approval of the recommendation as stated.
Lynette can second.
Thank you. We have a motion and a second on the floor. Any further discussion on it? All right. I'll call for the vote then. All those in favor of the motion?
Aye.
Aye.
Any opposed? All right, we have unanimous approval on that recommendation. Then we have recommendation number 3.
And recommendation number 3 went to both the Plan Certification Committee and the SHOP Committee, and the recommendations were the same, and the wait, let me back up here a second. So the recommendation that the board approved was to allow carriers to offer QHPs in either or both exchange at their discretion, that QHPs not be required to be identical in the individual and SHOP exchanges. The recommendation here is to allow carriers to offer QHPs in either or both exchanges at their discretion, that QHPs not be required to be identical in the individual and SHOP exchanges, And then the second part is that certification requirements for QHPs offered in the shop exchange be no different than the requirements for QHPs in the individual exchange. So 3A has really been discussed and done with at the board level. You guys have already, the board has already approved that they that recommendation. But 3B, that the certification requirements basically be the same, we've not discussed. Obviously, administratively, it makes it simpler if the certifications requirements are the same. We couldn't identify any reason to change the requirements for the shop exchange versus the individual exchange. So the committee recommended that the certification requirements be the same for both sets of plans offered on either the individual or the shop exchange.
Do we have any questions?
Yeah, Ron Klein. I'm not sure I understand. I obviously understand A. I don't understand what B is. What are certification requirements as opposed to plan requirements?
So the certification requirements are the procedures used to do rate review to make sure that they are qualified health plans, that they can technically be they satisfy the information technology requirements to be offered on our exchange. All of those requirements. And again, this question was brought up and provided on the committee calendars, but again, we couldn't find any reason to have different certification requirements.
Mr. Hager, I guess I'm viewing that recommendation as really falling under the Division of Insurance rather than Health Insurance Exchange. Who issues the certification?
The Division of Insurance will issue the certification and the licensing, and they will work with us to come up with the proper certification procedures.
Okay.
So this is coming up with those procedures and making sure that there's no, either there is or isn't a difference. If there's something that we can identify that we feel needs to be addressed for a small employer plan versus an individual plan.
Any other questions? There being none, what is the pleasure of the board?
Ron Klein, I will move to approve recommendation B.
Do we have a second?
Lamar Lewis, I second the motion.
D3B.
Okay. We have a motion and a second on 3B. Any further discussion? All right, I'll call for the vote. All those in favor of the motion?
Aye.
Aye.
Any opposed? We have unanimous approval on that item. Okay. Moving on to recommendation number 4.
And again, recommendation number 4 was discussed by the Plan Certification Committee, and the board approved the recommendation to allow carriers to create QHPs that meet the requirements of the Affordable Care Act, that the exchange not impose any additional cost-sharing requirements on QHPs. This is the same discussion about creating standardized co-insurance, co-pays, and deductibles, and whether that makes sense for the shop exchange. I would say that if it makes sense anywhere, it would be the individual exchange as opposed to the shop exchange, and it wasn't. The committee did not vote to include it in the individual exchange. I believe that motion was approved unanimously. I'm not sure if we had one vote against that. It was number 4. But I have no additional comments to add on this one. There doesn't appear to be any specific reason to change that recommendation for the shop versus the individual exchange. And to be honest, I'm not sure if you even need to vote on it again.
Yeah, that's what I was wondering.
I would make a motion, if it's appropriate, just to be clear that we intend the action on the shop exchange.
This is Dr. Ford. I second the recommendation to allow carriers on the shop.
Okay, thank you. Yeah, so do we have a motion then to approve it so that we're consistent, or we did? Oh, Leslie, you did it already. I'm sorry, I was reading something while you were doing that. And who posed the second? Dr. Ford. Thank you. All right, is there any further discussion on that item? All right, I'll call for the vote. All those in favor of the motion?
Aye.
Aye.
Any opposed? Motion passes unanimously. What is this word? Recommendation number 5.
And number 5 is, again, the same recommendation. It was actually covered under the idea that each, I believe it was licensed carrier, offer no more than 5 qualified health plans per metal tier per market. And that word per market covered this recommendation, so there's no need to take a vote on this one.
Okay, so then if we just refer back to the recommendation number 5 under the plan certification, it picks up this recommendation as well. Is everyone on the board okay with that, or do you want a motion?
It looks like we're fine, Madam Chair.
All right, thank you. Moving on to recommendation number 6.
For the record, John Hager. So recommendation number 6 is the mind bender for a shop. There was quite a bit of discussion on this one, and this one, Dr. Klein, was the one that we had to bring back because of the error that we found in the recommendation when we were at our gate review in Washington, D.C. So the tables that you see on page 13, the idea is an employer will have the choice to select from one of these options, and when they select one of these options, when their employees go to purchase insurance, they see the plans that are identified by the X's. So, for instance, if a carrier if an employer offers all plans in the shop exchange to their employees, then the employee will be able to see every plan from every tier from every carrier. And so you can see option D, the employee sees everything there. It's a bingo blackout right there. So you can see everything as the employee. You can choose any plan in the shop exchange. Now the problem with this is carriers are very concerned about this because of adverse selection or the potential for adverse selection. They would like to try and control and mitigate the adverse selection as much as possible. In option B, the open metal tier, an employer would say, you know what, I appreciate that there's this thing called the open shop and there's all this extra, all these different options, but we're going to set a set of cost sharing. Maybe it's at the platinum level, and you would see X's at the platinum level. In this case, the employer chooses the silver level, so all of the plans that are in the silver tier are available for the individual to select. This option is required by the Affordable Care Act. So no matter how we structure the rest of the shop exchange, we have to offer every qualified health plan in that metal tier. So if an employer goes to pick the gold plan, then the employees will be able to choose from any gold plan in the shop exchange. Then the other option is option E, which is a package. So basically, a carrier could designate a plan or a set of plans as a package, and an employer would say, all right, I want a package option for my employees, and I'm going to choose package 1 from United or package 3 from Hometown Health or whoever. So the carrier could offer that. They could offer only a platinum plan as part of a package, or they can offer, say, a gold and silver plan. It's up to the carrier to decide how they want to put these packages together. That's fairly similar to how things are done today. Employer goes to a broker or to an insurer and says, hey, I want to get insurance for my employees, and the insurer says, all right, here is a group of products that we have for you. Here's one plan for all your employees, or here's 3 plans for them to choose from. So option E sort of mimics what's going on today. Carriers are are proponents of that option because it helps them mitigate adverse selection. They would prefer not to offer option D. They obviously have to offer option B. So basically the recommendation was that that the options B, D, and E would be available on the shop exchange. F is basically part of E. Let's pretend you have a carrier that's a regional carrier in the Las Vegas area and a regional carrier in Washoe County, and they could come together to form a package that they sell, and that allows an employer that has people both in Reno and Las Vegas to get plan coverage on the same plan. So basically that we allow on the shop exchange an open metal tier option B, open shop option D, which creates the greatest plan options for employees, and that is actually favored by the consumer advocates. And then that we offer a package option E and F. All shop qualified health plans must be offered for sale in the open metal tier, as I said, in option B. Additionally, a carrier may also place a shop qualified health plan for sale in an open shop option D, a package option E and F, or both. Qualified health plans offered as a package option may be offered in one or more packages. So it's up to the carrier to decide what market they want to play in. Obviously, they have to play in the open metal tier market, but if they want to, they can say, you know what, if an employer wants to offer plans to all of the if an employer wants to offer all the plans to their employees, then any plan that's designated as an open shop plan would be available in there. So you might have a carrier saying, hey, I want to be a part of that market, and so here we go, we're going to put our best foot forward with that. Conversely, you might have a carrier that says, you know what, there's too much adverse selection in the open shop market there, so we're not going to designate a qualified health plan as an open shop plan. We're only going to designate it as a package plan or an open metal tier plan, and if an employer goes to the open shop selection, they wouldn't see that qualified health plan there. They would only see it if they chose the package or if they chose the open metal tier. The employers will select one of the above options for his or her employees. If an employer chooses a package option for E and F, the employer will select a specific package for his or her employees. If an employee chooses an open metal tier option B, then the employer will select a specific metal tier for his or her employees. And then finally, employees will be able to select a QHP from the option, tier, or package selected by the employer. So really, that was basically the recommendation. The issue was balancing adverse selection and consumer choice, and so the result was allowing the carriers to have the ability to decide where they want to put their products, and then if they don't want to play in all the markets, then they wouldn't be chosen if the employer chooses that market. I hope that the illustration helps that a little bit, but please feel free to tell me that I wasn't clear enough.
You're right. This is a mind bender. Do we have any questions from Las Vegas?
Madam Chair, this is Leslie Johnstone.
Yes.
So, John, is basically the recommendation that we allow carriers to submit plans on the shop exchange and identify if they want to be included in the option B package, the option D package, or the option E and F package?
Yes, with the caveat that every plan that's on the shop exchange has to be offered in option B. But they can decide whether or not they want to put it in as a package or an open shop or both or neither.
All right. Thank you.
John, let me ask a question, and maybe I'm misunderstanding parts of this, but given the fact that we've just restricted the number of plans each carrier or trademark can place on, have we caused problems in this model?
I don't think so. You still have the restriction. If each carrier offers 5 plans in the shop exchange, you will still see all 5 of those plans in the open metal tier. So if an employer wants to go to the open metal tier, that's fine. You might find that nobody wants to play in the open shop exchange because there is simply too much adverse selection. My guess is you'll find somebody that wants to try and crack that nut and get in that market, but you may not. And then you also have the package options. So again, each of those plans can be part of one or more packages, depending on how they want to market that to the employers that are out there. So I don't think the 5 QHP restriction will harm this model at all.
I would just ask that, when time's a little calmer, take a look at that and just make sure we haven't caused an issue in here. Because I'm sure that from a consumer standpoint, some of those partner packages would be good for small employers if they've got offices north and south.
This is Ron Klein. I don't really understand this, but Dr. Ford and Ms. Johnstone say that's the right thing to do, so I'm going to vote for it. I'm easily swayed. We're all sitting here, John, a little bit concerned because you just said, that your primary concern is that nobody will play in the shop exchange, which was our concern when we had the recommendation about not restricting people to be in both or either, and now you just sort of said your concern is the same thing. So we all sort of took a double take down here, so maybe you could expand on that a little bit.
Yes, I'll certainly clarify. I would not be surprised if the carriers generally don't want to play in the open shop option D. I am fairly certain that we will get enough product, enough carriers to participate in the shop exchange in general, and those will be offered in the open metal tier options. So I think we've got option B covered. I think we'll be okay on that option. Whether or not we get players in option D or E, I'm not sure. This gives the carriers the flexibility to decide how they want to market their products, which should incentivize them to participate in the shop exchange to an extent. It also provides the opportunity for there to be the open shop options that you see in, say, Utah has the open shop option. Whether the carriers participate in that piece, the open shop option D, is unknown, but I'm pretty certain that they will provide there'll be a few products, at least a few products in the open metal tier option B option.
Great, thank you.
Any other questions?
This is Dr. Ford. I was just clarifying that the employer picks which option they want to offer their employees. So there's kind of 2 levels of choice here. First, the option which is picked by the employer, and then within that option by the employee.
Yes, absolutely.
Any other questions? Does anyone want to make a recommendation to approve the recommendation?
This is Dr. Ford. I move to approve the subcommittee's recommendations for plan organization to offer B, D, E, and F.
Thank you, Dr. Ford. Is there a second?
This is Leslie Johnstone. I'll second it.
Thank you, Ms. Johnstone. Any other further questions or comments on the motion? All right, all those in favor?
Aye. Aye.
Any opposed?
Aye.
Ms. Lewis, was that aye? You're opposing this?
No, I'm not opposing. I'm voting for it.
Oh,
it's just a late aye.
Okay, I just wanted to make sure my record was clear on that. So we have a unanimous approval of recommendation number 6. Thank you. All right, moving on to the last recommendation out of SHOP, and that's recommendation number 7.
So recommendation number 7 is in regards to minimum contribution and participation requirements. Typically in the small group market, carriers will require minimum participation rates of about 75% of eligible employees and minimum contribution rates around 50% of the total cost of coverage. However, some carriers have minimum contribution rates and do not have minimum participation rates. Additionally, these rates may vary based on the carrier's business models. These requirements help prevent adverse selection and are typically set by each carrier. If the exchange allows the package option, option E and F, which we just voted on unanimously, the minimum participation and contribution rates for the package QHP could be set by the carrier. However, in the open metal tier option B and the open shop option, option D, the exchange needs to set a standard minimum contribution and or participation rate for the employer for any QHP that is designated an open metal tier QHP or open shop QHP. The recommendation from the committee was for QHPs designated as package QHPs and E and F, the carrier set minimum contribution and participation rates. For QHPs designated as open metal tier QHPs or open shop QHPs, options B and D, the exchange set a minimum employer contribution rate equal to 50% of the lowest cost QHP available to his or her employees and a minimum employee participation rate of 75% of eligible employees. The participation rate is equal to the total number of an employer's employees who enroll in the shop exchange divided by the total number of an employer's eligible employees who do not have other minimum essential coverage.
Any questions?
Madam Chair, I would just have one question. This is Leslie Johnstone. The 50% of the lowest cost qualifying health plan available, is that complicated by this temporary subsidy that would come into play? Potentially.
Ms. Johnson, are you referring to the tax credit for small employers?
Yes.
It would not, no.
Oh, okay. Okay.
The tax credit comes at the end of the year, and this would be, and the tax credit goes to the employer. This is the amount of money the employer puts forward to pay for their piece of the premium as compared to the amount of money that the employee puts toward their premium.
I was just thinking because the credit is coming back to the employer for the cost, whether or not that should be netted out or not.
I would say that
it should. Opinion one way or the other.
It should not be included. I think it's a tax credit that goes to the employer at the end of the year and would be separate from the purchase of insurance.
Okay. With that understanding, I'll move approval of the recommendation.
Okay, do we have a second?
This is Dr. Ford. I second.
Thank you, Dr. Ford. Is there any further questions or discussion on this recommendation? Dr. Klein? The camera's moving that way. I can't tell if somebody's...
I'm waiting to vote aye. So just,
Okay, then I'll call for the vote. All those in favor?
Aye.
Aye. Any opposed? The motion carries unanimously. See, every one of those recommendations unanimously, and the chairman of the subcommittee is not here. That ought to tell us what to do in the future, right? Anyway, well, thank you very much, everyone. Let's see. Risk and reinsurance and risk will be covered in October. So we are now I think we've covered everything that we need to under that agenda item, haven't we, John? Yes. Okay. So let's close agenda item number 8 and move on to agenda item number 9, possible action, dates, time, agenda items for future meetings. Is
So the next board meeting is scheduled for October 11th at 1 p.m. We're moving. I'm sorry. It's on Tuesday, September 18th. The next normal board meeting is on October 11th, but the special board meeting we're having on September 18th will be at, and I believe the time is incorrect on agenda item number 4. It should be 2 p.m. It's posted as 2 p.m. So we'll see everybody here on Tuesday to talk about our favorite subject, essential health benefits, at 2 p.m. The next board meeting after that is October 11th, and at that meeting we'll talk about the risk adjustment recommendation and the navigators, producers, and outreach specialists. There may be a few other recommendations that are provided by committees at that point. We played with the fact of potentially not having an October meeting or a December meeting. Given the holiday season, it might be better to defer that and potentially not have a December meeting, but we can talk about that maybe in November and see where we're at. We will also bring back in October a process for regulations. The exchange is exempt from the Nevada Administrative Procedures Act, NRS 233B, but it would probably be important that we create a process for us to follow. During the bylaws discussion, we talked about making sure that the regulation process was transparent and as in line as possible with the normal regulatory process. I believe the reason that we have an exemption is because of the fast-moving nature of this implementation and the fact that regulations continue to come out from CMS. So while it would probably be appropriate to have, say, a 30-day notice period, we can move forward with not going through all of the procedures of the Nevada Administrative Act. So we will come with a recommendation for that to start our regulation process in November, and a few of the other items that are on the calendar, on the board calendar. With that, I'll be happy to take any recommendations for additional items if there are any.
Lynn Atkins. John, at that next meeting, and Madam Chair, if you deem appropriate as well, I know we're going to be voting on a lot of the consumer assistance matters, including the navigators, producers, and consumer, the assistance specialists. I don't know why the name just escaped. Thank you, outreach specialists. Could we also take a look at the budget? I know, John, we've talked about this before, but can we also take a look at the budget in relationship to those things? I'd love to have that big discussion here when we review those items, and how much is currently budgeted for navigators, for outreach specialists, and kind of the game plan on that. Again, it's my continuing concern about capacity. I want to make sure our troops are in place.
Absolutely.
And then, thank you for that comment or recommendation, Ms. Atkins. That's a very good idea. What I would like to do under this agenda item is just briefly bring you up to date on what happened today at the Plan Certification Committee, which is what we will be dealing with next Tuesday, September 18th. The advisory committee went through all of the recommendations on the various plans and have identified 3 potential plans that they believe would qualify for the essential health benefits plan that would be the most comprehensive and the most affordable for consumers. What we have asked is that the carriers and anyone that is participating in that meeting give us public comment on that so that we can bring that all to you on Tuesday. A lot of the information was not available until yesterday, and so there was public comment, but a lot of people needed some more time in order to review the materials that were given to us today. So just to bring you up to date on that, there will be 3 essential health plans that will be brought to you for your consideration next week, Tuesday. And hopefully a lot of public comment will be coming John's way for us to consider. So unless there's anything else under item number 9, we'll close that agenda item and open it up for public comment. And then, Ms. Johnstone, will you help me with public comment in Las Vegas?
None here, Madam Chair.
Okay. Is there any public comment here in Carson City? No, quiet time here too. How about on the telephone? Doesn't sound like there's any there. Well, again, I want to thank everyone for their preparation and their time and commitment to this project. And with that, we adjourn the meeting, and we'll look forward to seeing everyone on the 18th.